Hi, this is Conrad Fisher. I'm Associate Professor of Medicine at Touro College of Medicine. And acute chest pain, gee, this is an awfully common reason to visit the emergency department. It's not the most common. What's the answer to the question? The most common reason to visit the emergency department is a exacerbation of congestive heart failure. Now, of the 6 million people who come with chest pain, about 8 or 10% ultimately end up having a myocardial infarction. Another 10 or 12% have an acute coronary syndrome. 50% have nothing cardiac at all. But out of those millions, it's about 8% ultimately that have a myocardial infarction. Now, in patients with chest pain, you need to exclude the most dangerous thing first. Even though only 8% ultimately have a myocardial infarction, you've got to start with ruling out, with excluding the most dangerous things first. Because the anxiety and the gallbladder disease is not what's going to kill your mother. What's going to kill your mother is the acute coronary syndrome, aortic dissection, pulmonary embolus, a tension pneumothorax, and a pericardial tamponade, and sometimes esophageal rupture, which is a more clear term than saying Boer-Haves syndrome. Now, the history of acute chest pain is far more important than physical examination. In fact, there are no unique physical findings for coronary artery disease. There is no unique finding for an acute myocardial infarction. Isn't that strange that the most common cause of death in the entire country should have no unique physical finding? My goodness, you would expect it there'd be like a little tattoo that would pop up in people's chest that says, blockages found in here. But nothing is specific for the myocardial infarction. People can have a valve rupture causing a murmur. They can have an S3 from congestive failure. They can have an S4 from ischemia causing left ventricular non-compliance. However, you can have a myocardial infarction with none of these, and you do the majority of the time. Therefore, you look at risk factors. Now, risk factors are most important in patients in whom the diagnosis is not clear. When you have a person who's a 75-year-old guy who has exertional chest pain and that gets relieved by rest, exertional chest pain, an older man doesn't need risk factors because the diagnosis is so clear. But let's say that you had a 45-year-old man or a 38-year-old woman. You say, what's this 45-year-old man or 38-year-old woman doing with chest pain? Well, then you look to the risk factors. Then you look to the hypertension, diabetes, hyperlipidemia, tobacco smoking, and the family history. Do I see any? Hypertension, diabetes, hyperlipidemia, family history. Do I see the family inside of you? Yes, that's when risk factors make a difference. Now, the other things you're going to do to evaluate chest pain are, what is the onset and duration? For instance, real ischemic pain is not for a second, and it doesn't last for 12 hours. It lasts for a few minutes or 20 minutes. Next, it's not sharp like a knife. Sharp like a knife is not ischemic. Ischemic pain is dull, like being punched. It's sore. It's like, remember when you once actually went to the gym before you were studying the step 2 all the time? Well, it'd be like a sore muscle, like you're exercising a lot. Sometimes it radiates to the arm, and the localization. Where is the location of real ischemic pain? The heart's in the left side of the chest predominantly, so where do you think the pain would be if the heart is in the left side of the chest? Oh, it's not in the left. Isn't that amazing? The heart is in the left side of the chest. Yet, the pain is not on the left side of the chest. It's like I have appendicitis and I get right upper quadrant pain. Why it's not there? Why is that an ischemic heart disease? I've got a short answer for you. I don't know. Nobody knows. But ischemic pain is substernal, and non-ischemic pain is right-sided or left-sided. Ischemic pain is substernal. It lasts for 10 or 20 minutes. It's dull like being punched. And the most important thing is, does it happen on exertion or not? Exertional chest pain that's substernal and dull, like being punched. That will give you the answer to the question, which of the following is the most likely diagnosis? Diabetic patients with coronary syndromes can have atypical symptoms, such as no symptoms, so-called silent ischemia. Now you might say, well, how am I supposed to make the diagnosis of silent ischemia if they come in and it's silent? Are they supposed to say, hi, I just wanted you to know that I'm feeling fine today? Now, how the case will be described is a person can come in and it says, on admission, they're found to have Q waves. On admission, they're found to have congestive heart failure. So when we say silent, we don't mean completely asymptomatic. We mean instead of chest pain, you have an anginal equivalent. Those anginal equivalents can be shortness of breath, fatigue, or just feeling dizzy, nauseous and lightheaded and vomiting because inferior wall MIs press on the diaphragm. So diabetics can have substitutes for chest pain, such as shortness of breath or syncope. In the history, if the pain is described as sharp, knife-like, and can be localized to an exact area, it's less likely to be related to ischemia. So the comorbidities to ask for is hypertension or diabetes or peripheral vascular disease. Remember, peripheral vascular disease, which should be more properly called peripheral arterial disease, because we're not concerned with the veins, we're concerned with the arteries. So peripheral arterial disease, PAD, because PAD is bad. Peripheral arterial disease is bad. Now, what these mean is that when you have a person who has peripheral arterial disease, you should pretty much assume that the same disease process is happening inside the coronaries. After all, what's the difference between my femorals and my aorta and my coronaries and my carotids? They are so similar, essentially they are equivalent. Now, trauma makes a history difference only because chest wall trauma will make a difference. Now, immobilization is important, not for myocardial infarction. Immobilization is important because it's a risk factor for a pulmonary embolus, which is one of the causes of chest pain. Now, alcohol itself, does alcohol actually cause coronary disease? No. Alcohol causes cardiomyopathy, but not coronary disease. This is one of the common misunderstandings, that alcohol is a risk factor for coronary disease. The same way, does alcohol cause ulcers? No. It can delay their healing, but it doesn't cause ulcers. Smoking definitely causes coronary disease, and when the drug abuse, it's really specifically saying cocaine, because cocaine causes chest pain. Does heroin cause chest pain? And the answer is, hey man, hey, listen, can I have another bag of hair? No, actually, you could kind of call it protective, because it keeps you too slow to actually do anything, lowers your myocardial oxygen consumption. And on history, remember that the family history has to be young. Family history has to be a male relative that is under 55 or a female relative that is under 65 for a family history to be significant. Now, in the history of chest pain, does the response to nitroglycerin help you to make a diagnosis? And the answer is absolutely not. The relief of pain with nitroglycerin does not distinguish cardiac versus non-cardiac causes. It's just too non-specific. You can't say, oh, this person's pain went away with aspirin and nitroglycerin, so therefore it's cardiac. No. Number one, pain often stops spontaneously. The second thing is, it could be that it's esophageal spasm and muscular pain. Now, nonspecific symptoms like nausea, vomiting, and sweating and shortness of breath will not help you, since so many things give you nausea and vomiting and sweating. I mean, I sweat. It doesn't mean I'm having a myocardial infarction. In the physical exam, which doesn't give the distinction of what coronary syndrome, if any, it may give you some clues for the diagnosis. For instance, fever is more common with pneumonia and PE mediastinitis. Why does a pulmonary embolus give you a fever? Well, any clot or any collection of blood can give fever. Any clot and any collection of blood. A hematoma, PE, DVT, gives me a fever, inflames me. Pulmonary embolus, any clot or any collection of blood. The problem with tachypnea and tachycardia, although they're sensitive for pulmonary embolus, they're terribly nonspecific. However, a normal heart rate 95% of the time means you're not having a pulmonary embolus. A normal heart rate. Now, although it's insensitive, there's a difference in blood pressure between arms. That is a strong clue for aortic dissection. However, the problem is that it happens just about 5 minutes before you're dead. So blood pressure differential, if it's there, it helps you. Hypotension can happen from any cause of myocardial infarction complication. Low blood pressure is common to all complications of MI. So it can occur with a pulmonary embolus or from congestive heart failure, from PE, from myocardial infarction, from rupture of the valve, from septal rupture, wall rupture, valve rupture, septal rupture, third degree AV block. They all can give hypotension. So it's non-specific. In terms of physical findings and lung sounds, there's rowels and crackles indicating congestive heart failure. There can be asymmetry of breath sounds indicating a pneumothorax, decreased breath sounds on one side, or absent breath sounds on one side, which could be either a pneumothorax or a pleural effusion. Chest wall tenderness is extremely important because chest wall tenderness is one of the things that has a 95% negative predictive value. In other words, chest wall tenderness, positional pleuritic or tender, all have a 95% negative predictive value. Asthma, the findings of looking at accessory muscles is one of the most common wrong answers because it's not there most of the time. Subcutaneous emphysema is when you have rupture of an esophagus or rupture of a tracheobronchial fistula, which puts air outside the lungs and into the subcutaneous tissues, and you press on people's skin and it feels like bubble wrap. In evaluating heart murmurs, a wide split S2. Now you might say, oh my goodness, no one can hear about a wide split S2. How do we know which one you really have? And the answer is that even though you may not be able to hear it, you're supposed to know it's there. But I've never heard it. You're supposed to know it's there. But it's like a belief system. Is it cardiology? No, it's cardiotheology. Maybe you've never heard it or seen it directly, but you have to know it's there. So a wide split, meaning a delay in the P2. What delays the P2? My goodness, it's a right bundle branch block. Delay of the right side conduction. Right bundle branch block. Right ventricular infarction. Pulmonary hypertension, because it delays the emptying of the right side of the heart. If it delays the emptying, it delays the closing. It's a right bundle branch block. It delays the emptying, it delays the closing. Pulmonary hypertension delays the emptying, it delays the closing. Paradoxical splitting would be where the A2 happens after the P2. The A2 is happening after the P2. If it delays the emptying, it delays the closing. So when you have a delay to the emptying of the left side, it delays the closing of the left side. Paradoxical splitting. Left bundle branch block. I delayed the emptying of the left side, I delayed the closing of the left side. Aortic stenosis delays the emptying, it delays the closing. Hypertension, simple old-fashioned hypertension, delays the emptying of the left side, delays the closing of the left side, so it delays the A2. S4 gallop is atrial systole into a stiff or non-compliant left ventricle. It's indicative of any form of angina, which makes the heart ischemic. Ischemic things do not relax. Ischemic things don't need relaxation, don't get relaxation. I'm ischemic. I don't have ATP. I don't have ATP. I can't detach those actin and myosin filaments, can I? So therefore, when you're ischemic, you end up not being able to detach the actin and myosin. S3 is congestive heart failure. It's rapid ventricular filling during diastole. It's rapid ventricular filling during diastole. And new aortic regurgitation, one is from a dissection. Number two is rupture of the chordae tendineae, rupture of the papillary muscles with new aortic regurgitation. New mitral regurgitation, the same thing. Papillary muscle rupture, papillary muscle dysfunction. In looking at acute chest pain, acute coronary syndromes, and looking at the extremities, well, what's the point in doing that? The point in looking at the extremities is to be able to see, gee, is there signs of embolic phenomena to the peripheral arterioles, which might be loss of pulses? And also, is there a source of pulmonary embolus, such as with calf tenderness or edema? Is there a source of a pulmonary embolus? The other thing is that you can tell whether there's atherosclerosis in other parts of the body, because when you have atherosclerosis in your heart, you have atherosclerosis peripherally, and peripheral arterial disease is characterized by people who lose skin appendages. No hair, no sweat glands. No hair, no sweat glands. Might lose pedal pulses, particularly with an aortic dissection. And remember, unilateral calf pain suggests the pulmonary embolus. The electrocardiogram the EKG or ECG. By the way, you might wonder, why do some people call it EKG and ECG? Einthoven himself is a Dutch guy, and heart in Dutch begins with a K. That's why it's always called an EKG, in case you're wondering. So ECG is more precise, actually. In terms of evaluating this, remember, that's the only thing you can do right now to evaluate chest pain. Enzymes don't rise for 1 hour for the myoglobin, don't rise for 3 to 4 hours for troponin and CPK. The left bundle branch block has the same significance as ST elevation. So when you're looking at the EKG, you're looking for ST elevation or a new left bundle are indications for people who might have the need for thrombolytics. ST elevation or new left bundle. Cardiac markers, the specific biomarkers, the first thing to go up is myoglobin. Now, if you're a current student doing rotations, or you did rotations before you finished medical school, and you say, I never saw anybody do myoglobin. Yeah, you may have not have seen anybody do myoglobin, but it doesn't mean that you couldn't have done it just because you didn't do it. For instance, if you went to the emergency department and you had chest pain, you would appreciate a myoglobin negative at 4 hours. You'd be like, oh my goodness, I'm safe. I don't have acute coronary syndrome. My myoglobin is normal. How would you feel if somebody walked up to you and you go, look, I could do this myoglobin, but if it's negative, it means you don't have a coronary syndrome. But if it's positive, it's terribly nonspecific. You're like, dude, I will take the negative myoglobin now. Thank you very much. That's what you would do. We got a brand new thing. It's just invented called do unto others as you would have others do unto you. Brand new idea. So myoglobin negative at 4 hours means you don't have a myocardial infarction. A normal level excludes MI earlier than a normal troponin or CPK-MB. In looking at CPK-MB, CK-MB has been around for a long time, and it's quite a good test. It's still great. Early diagnose it begins to elevate at 4 hours, 6 hours, normalized after 48 hours. That's why it's very, very important, because it can tell you if somebody's reinfarcting. 2 days later, they have new chest pain. Is it a reinfarction or is it the same infarction? CK-MB. It's the answer to the question, which of the following is the best test to look for reinfarction? It has a bit less specificity than troponin and can be false positive with some other people who have damage to other muscles, but it's pretty specific. It's good enough to be able to tell you that a person who has a positive CK-MB is largely going to be a myocardial infarction, even though it may be slightly less specific than a troponin. Now, the other part about these is that troponins go up in kidney disease. Therefore, you can have a false positive troponin in a person who has chronic renal insufficiency. Looking at troponin, the troponin, it's hard to say anymore whether it should be only the troponin or only the CK-MB, and almost certainly step 2 CK is not going to ask you to choose between them. Troponin and CK-MB both go up at around the same amount of time, which is about 4 hours. They both peak at 12 hours or so. So therefore, you could say that a negative test before 4 hours means nothing. A negative test after 12 hours has a 95 to 99% sensitivity. The biggest difference is that troponin remains elevated for 7 or 10 days, whereas CK-MB will be normal after 1 or 2 days. So think of it like this: 1 or 2 weeks for troponin, 1 or 2 days for CK-MB. And troponin is falsely elevated in people who have chronic renal insufficiency since it's cleared through the kidneys. The CK-MB progresses to where it starts at 4 or 6 hours, peaks in 12 or 24 hours, and should normalize. The graph that you see on this slide is very good in terms of being able to represent to you how fast things peak and how fast they start to elevate. Now, troponin does not go up later than CK-MB. They both go up around the same time. That can't be used to distinguish them. They both elevate at 4 hours. Looking at a chest x-ray is one of those things that, on the one hand, should we do it? Yes. Should we do it in everybody? Yes. Chest x-ray should be done in everybody with chest pain. Point number 2, what does it show that tells you you've got a myocardial infarction on a chest x-ray? Nothing. The chest x-ray is looking for the other things that can cause chest pain. The chest x-ray is looking for pneumothorax or pneumomediastinum, pleural effusion, pulmonary infiltrates. It's looking for pneumonia, for pneumonia, a pneumothorax, a pleural effusion. And the other tests you get is blood gases if people are short of breath. Blood gas if people are short of breath. You get a BNP if there's the concern about congestive heart failure. BNP, how does it get translated from atrial natriuretic peptide to BNP? I'm not sure, but BNP is one of those tests that if it's normal, it's good. If it's normal, it's good. If it's abnormal, it means nothing. A normal BNP excludes congestive failure. Abnormal BNP means nothing. Spiral CT is what you're going to do to look for a pulmonary embolus. Spiral CT and CT angiogram are synonymous terms. They are used to look for the other diagnoses. A stress test is for people who are stable, meaning not having chest pain now. You can't put someone on a treadmill who's having chest pain now. You can't put them on a treadmill if they're having chest pain now. You got an equivocal person. They've got some risks. You're not sure. I'm not sure. My EKG is not diagnostic. I'm not sure. I'm not sure. I've been having chest pain off and on for a couple of weeks. I'm not sure. I'm not sure. Stress test. Yes, the stress test. You can't do it when somebody's got abnormal troponins. No, it has to be, hey, doc, I'm sitting in your office or I'm in the emergency room. I don't know. I'm not really sure. My EKG doesn't show it. My troponins are normal. What do you think I got? I'm not sure. Stress test. Now, if there's an unreadable EKG, we have to use nuclear. That's when there's an unreadable EKG. The other things that are not cardiac causes of chest pain, costochondritis gets worse with chest wall palpation and with inspiration. Anything that makes you move, because we want to be able to move and not have chest pain. I like to move it. You like to move it. We like to move it and not have chest pain. Hiatal hernia gives some reflux symptoms and better with antacids. Same thing with reflux disease itself. Remember that when there is chest pain and it's not cardiac chest pain, the most common cause of non-cardiac chest pain is reflux disease. That's the most common. The most common cause of chest pain when it's not cardiac is GI things. Reflux number one, but can also be ulcers. Ulcers is epigastric pain. Now, does ulcer pain have tenderness? Does it hurt when you press? And the answer is no. Ulcers are tender only 20% of the time, maybe only 10% of the time, but it's epigastric pain. Gallbladder pain should be in the right upper quadrant. Diffuse esophageal spasm is a pain that just happens. Diffuse esophageal spasm can just come at any time. It looks just like a myocardial infarction. It's substernal, but it happens at any time. So you can only say it's spasm after you've excluded all the coronary things. Pancreatitis is the number one thing to be associated with abdominal tenderness. Certainly alcoholics and stones, and alcoholics are stones. Hey, are we more alcoholic or do we more stoned than we used to be? Which one's going up? Alcoholism or stones? Alcoholism or stones? Which one's going up? The answer is stones. Because we're not more drunk than we used to be, but we are getting more stoned than we used to be. Isn't it true? Yes, we are. So alcohol's always been legal, but now the marijuana, okay, that's it. We are more stoned. Just think of it like that. More stones. Why? Because we're more obese. Obesity is going up, and that's why there's more stones. Mesenteric ischemia is intestinal angina. That's where you can have abdominal pain after you eat, because it's like putting your guts on a treadmill. Mesenteric ischemia. It has nothing to do with rest and can give you bloody stools, but you look at abdominal pain with eating. Panic attack. Ay, Dios mío. Ay, doctor. Ay, yo tengo mareo. Ay, 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 ay. My God, I think I'm having one right now. I'm having a panic attack. Oh, my God. Well, they're very hard to distinguish from real chest pain. You can't tell them apart until after you have an EKG and enzymes. Now, this one, post-herpetic neuralgia, you might think, who's going to mix that up? But it's really common. People say, oh, I have chest pain, and that dermatome can extend almost to the sternum, and you have chest pain, the dermatome extends to the sternum, and people have post-herpetic neuralgia that can really make people think that they have ischemic pain because it's in a similar location. Let's take a look at all the things also that can cause chest pain. How will I recognize the answer to the question, what's the most likely diagnosis, for all the many things that can be asked about on step 2? For instance, when you get a step 2 question, it's not labeled, hi, question 20 is going to be a cardiology case. It can be that it just says it's chest pain. You don't know it's cardiology. It could be like this one, pulmonary embolus or lung infarction. How will I know to answer the question, lung infarction? There'll be more shortness of breath, more cough, more hemoptysis, and here's the key issue, pleuritic pain. Pleuritic pain means it changes when you breathe because it rubs on the pleura. It's like chest dyspareunia. When it's rubbing with the movement, it hurts. Pulmonary hypertension doesn't give chest pain so much, but definitely does give shortness of breath. There are signs of right ventricular failure, such as ascites, edema, big liver, big spleen. Ascites, edema, big liver, big spleen. Ascites, edema, big liver, big spleen. Pulmonary hypertension. A pneumothorax gives very sudden onset pain and shortness of breath, and is also pleuritic because it begins with a P. It's pneumothorax. Myocardial infarction, the pain lasts a long time, not just a few seconds, more than 20 minutes. Aortic stenosis, well, did you know that 50 to 70% of patients with aortic stenosis also have coronary disease? Did you know that? 50 to 70% also have coronary disease? Why, it's amazing. That's right. That's why. Which of the following is the most common presentation of aortic stenosis? And it is chest pain. Now, most people think it's syncope, but it's not. The most frequent presentation of aortic stenosis is chest pain. The worst presentation is congestive failure. And although syncope occurs, it's neither the most common nor the worst because you can go in and take that valve out and resurrect your grandmother. Myocarditis can give any presentation, everything from shortness of breath to a little pain to outright congestive heart failure to outright pulmonary failure. You don't know which one it is because it has a broad range of myocarditis or can simply be asymptomatic. Pericarditis is pain that is positional and pleuritic. Positional. Does it get better when you lean forward or worse when you lean back? Is it better when you lean forward or worse when you lean back? The pericarditis. Is it better when you lean forward or worse when you lean back? And the answer is, it means the same thing. Better when you lean forward and worse when you lean back is the same thing. Dissection of your aneurysm. Well, I always wonder when people are going to take these histories, it says, is that chain tearing, ripping, or crushing? My goodness, how do people know like this? Bring out your thesaurus. But the thing about aortic aneurysm dissection, you see, the difference between life and the boards is in life, anything can be anything. But on step 2, if they want you to know the answer, they got to tell you something. So if they want you to know it's aortic aneurysm rupture, they'll have to tell you that it's going in between your shoulder blades. In between your shoulder blades. Pain that radiates to the back. Pain that radiates to the back. Mitral valve prolapse. Mitral valve prolapse, when it does have symptoms, the most common symptom, when it does have symptoms, because most of the time it's simply asymptomatic mitral valve prolapse. But when it does have symptoms, the most common symptom is chest pain, atypical chest pain. Atypical because it's not related to exercise. It comes, it goes, and nobody knows. It's here, it's there, it's everywhere. I've got a mitral valve prolapse, and I don't know why. The young woman's in pain now. I don't know why, I don't know why, I don't know why. It just happens. But not just I don't know why, nobody knows why. Why do we have pain with mitral valve prolapse is not clear. In aortic dissection, the pain features severe, sharp tearing, radiates to the back. If they want you to know, they got to tell you there's a wide mediastinum. That's why that's one of the first things, wide mediastinum. Blood pressure difference between the arms. Because as you dissect off the subclavian, the blood pressure drops in the arm where there's the dissection into the subclavian. The other symptoms that can happen is loss of peripheral pulses. Aortic insufficiency as it ruptures and rips and tears. I'll steal your soul as the aortic dissection pulls out a part of your heart and it feels like your soul is being ripped out of your body. And you get aortic dissection. And the dissection can go through your coronary arteries and cause an MI. Evil. The best initial test for aortic dissection is a chest X-ray. You should expect to find a wide mediastinum. The most accurate test is to do next a CT angiogram, MRI, or MRA. To be more precise, it's an MRA because it's an angiogram with magnetic resonance, and that is an MRA, or a transesophageal echo. Now, All three of these modalities, CT angiogram, MRA, and TEE, have a 95% sensitivity. Why do we tend to use CT angiogram more? Simply because it's easier to get. In a pulmonary embolus, the pain is pleuritic. Pleuritic means the pleura is inflamed, and as the two pleura rub against each other, the parietal pleura and the visceral pleura, you obtain pain as it rubs against each other. Now, the other symptoms of tachypnea, tachycardia, shortness of breath, and cough are non-specific. As a matter of fact, hemoptysis happens with anything that makes you cough. Happens with anything that makes you cough. EKG findings are non-specific, meaning that S1Q3T3 may happen, but it's not the most common. The most common is sinus tachycardia. S1Q3T3 may happen, but when there is the most common abnormality besides sinus tach, it's signs of right heart strain, right bundle branch block, right axis deviation, P pulmonale, which is a sign of the right atrium straining against all that pressure in my pulmonary artery. It's like right atrial tenesmus. It's a feeling of incomplete emptying that leads it to stretch. It's like diverticulosis of my right atrium, P pulmonale. For pulmonary embolus, after an X-ray, EKG, blood gas, which must be done, the most accurate test that gives you a specific diagnosis. In other words, how do you get to a precise diagnosis? Why, spiral CT. Just remember, spiral CT is saying the same thing as CT angiogram. Ventilation perfusion scan is never first anymore. VQ scan has fallen down, and it's only when you can't get a spiral CT, it's when the spiral CT angiogram is not one of the choices, then ventilation perfusion scan. Also, a ventilation perfusion scan, in order to be accurate, must have a very normal X-ray. But ventilation perfusion scans has gone the way of rotary telephones and CDs. You could use them, but people will say, what are you using it for? You're out of date. You look funny doing it. It's not as accurate. Dopplers of the lower extremity are good if they're positive. Hey, I see a clot in your legs. Well, you don't have to do anything else, because that clot in your legs means you need heparin and 6 months of Coumadin, heparin and 6 months of rivaroxaban. Why, you have that clot in your legs. You need heparin and 6 months of warfarin, which is Coumadin, and rivaroxaban or dabigatran. So it doesn't actually change your therapy, does it? D-dimers. When is D-dimers? The answer, D-dimers is like a sedimentation rate. It's very good if it's negative, but it's non-specific if it's elevated. So negative D-dimers means very small likelihood of having a clot. It's good if it's negative. It's very non-specific if it's positive. Pericarditis is pain that is sharp, positional, pleuritic. It's worse when lying down, better when leaning forward. There is a rub. A rub is a triphasic rub that has 3 components to it, but it's only present in about a third of patients. The pulsus paradoxus is not present in pericarditis. The pulsus paradoxus is present in tamponade. Pulsus paradoxus means a greater than 10 millimeter decrease in blood pressure when you inhale. Pulsus paradoxus is a greater than 10 millimeter decrease in blood pressure when you inhale. In other words, a normal blood pressure to get a radial pulse, how much blood pressure do you need to have a radial pulse? Why, about a systolic of 90. So if you have a pulsus paradoxus and your blood pressure goes from 105 to 85, from 110 to 85, you breathe in. You breathe in, and you lose your pulse. You breathe out, you regain your pulse. You breathe in, you lose your pulse. You breathe out, you regain your pulse. Why, look at that. He breathes in and he loses his pulse, but he's still alive. That's so paradoxical. How can you lose your pulse but still be alive? Because you have tamponade. Well, why do we call it tamponade, not lemonade? Maybe you should drink lemonade and treat tamponade. No, because tamponade's a French word. That's why. It's got that in there. That's why, tamponade. Hey? If lemonade was invented by the French, we'd all be drinking lemonade. But it's tamponade. And tamponade means that the right ventricle gets bigger when you breathe in. But now there's no room for the heart to expand, so it squishes the left. What happens to venous return for the lungs when you breathe in? What happens to venous return? Well, the venous return to the right side of the heart increases. That's the whole point. The venous return to the right side of the heart increases when you inhale. The right venous return to the left side when you exhale. Left when you exhale. So when you breathe in, the right gets bigger, the left gets smaller, and your blood pressure goes down. What's a Kussmaul's constrictive knock? A constrictive pericarditis gives a Kussmaul's and a pericardial knock. A Kussmaul's, a constrictive knock. Well, a Kussmaul's sign is an increase in jugular venous pressure when you inhale. It's an increase in jugular venous pressure when you inhale. Now you might say, how come you don't get a Kussmaul's with tamponade and a pulsus with constrictive pericarditis? And the answer is you do get both with both. It's just that tamponade is mostly with the pulsus paradoxus, and constrictive pericarditis is mostly with the Kussmaul's. Kussmaul's is an increase in jugular venous pressure when you inhale. The enzymes might leak a little bit with pericarditis. They're usually normal. They might leak. And the best initial therapy for pericarditis is anti-inflammatories like non-steroidals. And what's the newest thing? Hey, let's get a 260, a 270 on step 2. And you get a 260 or 270 on step 2. You say, I know the stuff that decreases the risk of recurrence of pericarditis. And what decreases the risk of recurrence of pericarditis? Why, it's colchicine. Colchicine decreases the risk of recurrence with that pericarditis. Ooh, let's look at this EKG. Those arrows must mean something. Those arrows are showing ST segment elevation everywhere. It's got ST segment elevation everywhere. The other thing is PR segment depression. PR segment depression. PR segment depression is pathognomonic for pericarditis. Nothing else have it. And the last thing is, remember that pericarditis, the EKG evolves just like in a myocardial infarction. That EKG evolves just like in a myocardial infarction. She'll go from ST elevation everywhere to T wave inversion everywhere. It evolves. Myocarditis. Myocarditis often is preceded by a recent febrile illness. Now, myocarditis most of the time is viral. We never make a specific organism diagnosis. That's because the most accurate way to make a diagnosis is you have to do a biopsy of the heart with a right heart catheter. And since we don't want to do that, we just presume it's myocarditis. The pain can be pericardial type pain, it can be pleural pain, it can be nonspecific chest pain. The truth is that there's just no unique presentation to myocarditis. There just isn't. Zero. The good news is, if there's no specific presentation, it means you can't be asked a specific question on step 2. You could have a person who's got congestive heart failure or just a little fast heart rate, or conduction defect as the virus or infection inflames your conduction system. Next, the total CK and CKMB are elevated because as the muscle is injured, it leaks enzymes like troponin and CK. There is no specific finding on an EKG for myocarditis. You could have sinus tach or nonspecific repolarization or conduction abnormalities, ST elevation, ST depression. Again, nothing specific. Musculoskeletal disorders are a very common cause of chest pain, and they are preceded with pain that is stabbing and located reproducible by motion or palpation, and it can be pleuritic as well if you take a deep enough breath. The major way you'll make the diagnosis is by the person has their chest wall palpated, and the pain is reproduced when you palpate the chest. You can have costochondritis doing it, or just have rib fractures doing it, and the most important thing is, do you have a normal EKG? And normal enzymes. GI disorders are the most common of all causes of chest pain when it's not cardiac. The pain can definitely mimic angina pectoris, and the heartburn is because it's a different quality as the acid refluxes up through the stomach and into the substernal area. And it can be changed with food. The key issue is not so much whether it's worse after or before meals, but so much that it's simply changed by food. Ischemic pain is not changed by food. Ischemic pain is not changed by position. Ischemic pain is not relieved by antacids. Ischemic pain is not changed with position, pleuritic, or food. People are nauseous and can vomit and can have some regurgitation with it. Now, in the past, we used to use an upper GI series. An upper GI series with barium is essentially a passé test. And when you see upper GI series, although it can be done, it should be considered the most common wrong answer, because you can't tell if there's Helicobacter with an upper GI series. You can't tell if there's cancer with an upper GI series. You can't tell anything except, hey, there's an ulcer, there's no ulcer. Manometry is done when you're looking for spastic disease, and endoscopy is the accurate test for ulcers. Pneumothorax pain is pain that's very sharp, sudden, and is pleuritic in nature. And that is because as you have the pneumothorax irritates your pleura. You're going to look for shortness of breath, and in very severe ones, you'll have absent breath sounds. But you should not expect absent breath sounds unless the person has a real large pneumothorax. A small one will only be seen on chest x-ray. Now, on the chest x-ray, which shows the pneumothorax with greater accuracy, the inhalational film or the exhalational film for the pneumothorax? It's the exhalational film, because when you exhale, the lung looks smaller, but the amount of the air stays the same. The lung looks smaller, but the air stays the same. That means that the air looks proportionately larger. Pleuritis is pain of the inflammation of the pleura. It's sharp and changes with inspiration. There can be a friction rub because of pericarditis as it rubs on ya. Dullness to percussion is when there's an effusion. And you look for any infection, any cancer, any connective tissue disease. Any infection, any cancer, any connective tissue disease.